so much. Thank you very much, Danny, and I'd like to thank the organizers, Bob and Deborah, and all the support that SUNY Downstate has given to this, as well as the opportunity to share with you. I'm speaker number 43, so if that's any consolation.
42.
Oh, 42? I miscounted. So I was asked to talk a little bit about clinical cerebral vascular disease and administrative data sets, large databases that can help us understand things related to stroke disparities, which is a focus of a lot of what we do in some of our clinical research in neurology and stroke, and also treatment. And also I wanted to emphasize the idea of administrative databases. I see we have residents, junior faculty here. These are excellent databases to work with for creating pilot data and for residents and junior faculty to get good quality publications that can lead to more advancement in their research careers. So I just wanted to put a plug in for that. So I just wanted to chat about a couple of projects and then end with just some of the new ongoing things that we're hoping to address. So one of the things that we looked at was disparities in the use of intravenous TPA. As you may know, stroke is a medical emergency. It's time-based. And there may be reasons why people don't get access to TPA. They could be rural. They could go to underserved hospitals that don't have resources. There could be a whole slew of reasons why people don't get access to TPA, and we wanted to look at it in a temporal trend. So large administrative databases are nice because they can look at blocks of time sequentially to allow you to make some hypotheses from some of the retrospective data that you look at. So we looked at whether or not hospitals were designated stroke centers or not, and we worked with the New York State SPARCS data set, which is an excellent data set administratively. It's population-based. It's all the hospitals in the state of New York. We have people like Mohammed Faisal, who is a very gifted wizard on large databases, who's a major collaborator on a lot of these projects, who can get these data analyzed and cleaned up in ways that allow for meaningful publications. So basically we looked at trends in use of TPA over time. I'm not going to go through the exact numbers and data because you probably have 84 zillion pieces of data in your head already from what's gone on today. But basically looking at racial issues, looking at ethnic issues, and seeing what degrees of change there were over time with TPA use. And we found that the good news was that TPA was increasing over time, and there were some disparities based on race. There were some disparities based on age. People tend to not want to give TPA to older people, even though there's no good data to support not giving it. Hospital geography was important, and stroke's designation status for the institution was important for that. Here's another project that we also used SPARCS database for. This is one of our stroke fellows, Dr. Kim, a few years ago, who's now faculty down in Washington, D.C., that allowed us to ask a clinical question that is extremely common in medicine, which is the patient that comes to the emergency room with dizziness. And you could have spinning sensation, vertigo, a sense of imbalance. And so what to do with these patients? Is it peripheral? Is it an inner ear problem? They don't have to be admitted, or is it a central problem where they may have a brain stem or cerebellar injury that needs to be obviously addressed more seriously? So we looked at, again, using the SPARCS data set, characteristics that might be predictive, looking at positive predictive features of these patients and negative predictive features of these patients that would allow us to be able to determine if there were a series of independent predictors with a logistic regression that would allow us to be able to make some statements about who's high risk, who's low risk for what might be a serious event with a sort of non-specific symptom, if you would, such as dizziness or vertigo. So that was a project that led to a first author publication for our stroke fellow and had a lot of collaboration from Dr. Faisal again. And then finally, this was data that we did with a national survey back in the day when the National Stroke Association was alive and independent and had now over years declared bankruptcy and bought out by the American Heart Association, but they were very supportive. We got a PCORI grant, one of the first pilot PCORI grants, to try to develop patient and caregiver-centered mobile application devices, because as you know, everybody lives with their phone and does everything on their phone, basically. It turns out people use it as their computers, but there's differential access. Obviously, there's disparities to technology based on age, again, race, ethnicity, location, geography, rural, et cetera, internet access, cost. And so we actually developed a national survey and a local survey in Brooklyn to address what things would be preferable for people based on their age, their ethnicity, their gender, where they live, to put together mobile applications that would allow us. And we found very interesting findings that we thought could help us develop it. Since this was a pilot grant, we now will take this data and try to propose using this data to help us develop mobile apps and test them in the current clinical situations where more and more people now every year are getting mobile apps put on their cell phones. So I'll just close with some ongoing collaborations. I've also been fortunate to be working with some of the folks in the School of Public Health, Dr. Affable. We're also working with Dr. David Kaufman and Mohammed Faisal, Ms. Jumbo, and statisticians to, we have an R21 that's hopefully we will hear any day that will be funded to actually look at digital health platforms to control blood pressure in stroke disparities issues for people who, can they use their mobile devices and additional services to help improve their blood pressure control, which is the #1 risk factor for stroke and is obviously treatable. And we just put in a SUNY seed grant. It's not a commercial for anybody grading those grants here, but looking at discontinuity, we found that in our population at SUNY Downstate, we have a tremendously high and really unacceptable rate of lack of continuity of care from the hospital back to the clinic. Multiple reasons. So we've created a large data mining project where we have thousands of patients, and we're going to look at what some of the predictors are and other issues as it relates to follow-up and looking at trajectories so we can get a better handle on loss to follow-up and continuity of care in our population. The other thing that I do as well is help develop clinical trials, both in neurology and stroke and neurologic emergencies, and we have several active clinical trial networks that allow us to do randomized trials, phase 2 or phase 3 trials within the stroke world and the neurologic world that we try to get our residents and fellows and faculty involved with as well. And I'll thank you and end at this point.